Okay, I'm pleased to be joined by, I hope I can say, my very good friend and longtime confidant in my own research journey, Dr. William Cromwell, who I hope you don't mind if I still occasionally call you Bill. Is that okay, Bill?
People who know me call me Bill. People who don't know me call me William, so that's fine.
Fair enough. I think it's worth, before we get fully into it, I think it's worth really emphasizing something that I've said many times online and that I want to be sure that I say here on this video. In the earliest days, it was a bit difficult getting somebody of your caliber who I could just, bounce ideas that I had with regard to lipids, how they work, what the existing research is. And without question, you were one of the most responsive, if not the most responsive voice that I was able to connect with both online and I'm happy to say actually came here to Las Vegas and we got to sit and have a very long lunch that was around 3.5 hours. So let me just open up by just giving you a long thank you. I can't believe we've gotten this far along. And I can't express enough appreciation for how much you've been foundational to my research and how I've been able to progress on this journey.
Oh, well, I appreciate it. It's been fun. And I have to say, when we were looking at some of the first data together, I was really surprised at how quickly there were lipid phenotypic changes with what you were doing with your own diet. And one of the reasons I think it took a long time for us to have that breakfast was just for me to recalibrate my thinking of how quickly lipid physiology can change under various dietary conditions. Not that it doesn't change, but that it can change very rapidly was a bit of a new learning to me. And so that's where I think I looked at your data to say, where have we missed this before and how reproducible is this?
Yeah, myself, that's part of what I loved about this was very early on when I realized I could just get a fairly advanced lipid panel in the form of a nuclear magnetic resonance test, direct to consumer, just going online, ordering it myself. And now, if I not to fit in a plug for the service we offer, but we ourselves now offer through Own Your Labs the same thing. Where basically it's just a reselling service where you just go to LabCorp, get the blood work yourself, and then find out. I was doing it rapidly. I was getting NMRs. I want to say I got 8 NMRs over the course of 3 months and carefully tracked my food. That was literally the very beginning. And I still stand by rapid frequency of testing can really illuminate a lot of things very quickly. But as you know, a lot of the studies, certainly many that you've been a part of and that just happen throughout science, they like to get those tests very infrequently, but over a larger population size, over lots and lots of people. But I feel like we could learn a lot if we got a lot of uh, a lot of people who are very motivated, maybe in a smaller number, but who would do it with a higher frequency, which of course is a little bit of a tease for the experiment we'll go into in a moment. But yes, that's what I think has been very helpful for all of those initial experiments that I was doing to help teach me what my lipids were doing from within my body.
Well, to your point, I think we have the carrier and sea mentality. Things change, but they change somewhat slowly over time. So, at least in large outcome studies, you're looking for bulk effects over a long time. And if you're looking for a bulk effect over many years, no need to check very frequently. And then, as just a matter of clinical habit, when we see patients in the clinic, it's usually at 3 month intervals. So, if you're going to see somebody at 3 month intervals, you get the labs close to the time that you're seeing them. And left to your imagination is what's happened between when you saw them in the next lab because you're not looking. So, we kind of have that as a mindset. And then the third thing are just the kinetics of drugs that we use. You think about statins, for example, they're steady state at 6 weeks. Nobody's checking before 6 weeks because things aren't quote unquote steady state. And as a result, our mindset of when we check and why we check has always been a bit on the longer side.
Yes, now to kind of set up both who and what we're going to be talking about, I'll open with, and I'm pretty sure you were familiar with it at the time, one of probably the most talked about experiments I did was the white bread and processed meat experiment. What I was seeking to do was I was seeking to see how rapidly I could drop my LDL from its high at, I want to say it was 296, and ultimately dropped it down to 83 in a matter of 7 days. But this was with a swap. I was swapping out my ketogenic diet and swapping in carbohydrates. And to be fair, that was around a 14-day experiment, all said. But I would eventually connect with Dr. Nick Norwtiz, a PhD out of Oxford, who now is a Harvard Med student. It's very, he's extremely talented. I'm sure you'll agree. He had already written several papers by the point that I had met him, and he got very excited about this model. And he himself is this phenotype that's very central to all of us now, this lean mass hyperresponder. He helped me to get this into the literature along with our good friend and colleague, Adrian Sotomoda, and many other doctors and researchers. And he really wanted to take this an order of magnitude higher. So he came up with an experiment that I would like to have you describe, but I'll just emphasize before you do that when he was asking me who he would like to partner with, who I would suggest, I put your name up first. And I'm just so thankful that both of you were able to take this on. So imagine nobody knows anything about our research or us. How would you describe to a colleague what this experiment was and what its results were?
Sure, I would echo that. Nick is very talented and a good critical thinker, a good scientist. And so, from that perspective, as you said, he himself has the phenotype of being a lean mass hyperresponder. And for various reasons, he's been on keto diet for a long time. He's found clinical value in being on a keto diet. But as you apply keto principles, depending on the amount of carb restriction you have, you can get into this issue of having higher and higher LDL cholesterol. So his idea was to kind of tag on to what you did, and that is if this is driven by a physiology in which you have depleted glucose stores and glycogen from the liver, you're a lean individual, and your LDL cholesterol has gone up in a way due to the lipid energy model, for example. Could it be the case that adding carbohydrates back to the diet would basically reverse this process, which resulted in very high LDL? So if it's a carbohydrate refeeding that's responsible for the drop in LDL, does it matter what carbohydrate you have? Does it have to be a certain type of carb? Does it have to be a grain? Does it have to be a processed carb? And so what I thought Nick did that was very interesting, he said, well, let's pick a carb that people wouldn't think is very healthy. Now, there could be a lot of things on that list, but he chose Oreo cookies, right? So nobody would look at Oreo cookies as a health food, and nobody would look at it as something you would intervene with in somebody's physiology. And yet, if the idea is that a carb is a carb, and if I introduce carbs sufficiently back into a system that is awry because it's having to transport lots of fat to burn energy, right? So this was the idea. Let me, in his words, let's go on a ketogenic diet, stable baseline, usual activity, everything as it normally is, but with an LDL cholesterol that's quite high, in excess of 350. And let's, in that setting, introduce Oreo cookies, 100 grams of glucose a day in the form of Oreo cookies, and see what happens to LDL cholesterol. And then after that has happened for a period of time, stop that experiment, wash out, go back to your baseline everything. And then with LDL cholesterol back to a high baseline, try statin therapy to see what effect statins would have in lowering LDL, as that is one of our most common means by which we treat patients. And not just any old statin, rosuvastatin 20 milligrams will be considered a high intensity statin. And since it takes 6 weeks or so for that to become steady state, check this regularly over a period of time to see what the nadir is for the LDL cholesterol on the statin. So that's the experiment. The experiment is to take a case study of somebody who is a known lean mass hyperresponder, who has a baseline LDL cholesterol that's quite high, introduce carbs, see what the effect is, wash out. Then once you're back to baseline, treat with statins for a period of 6 weeks and see what happens.
And let's not bury the lead. What happened?
Okay. So that's the design. And the experiment was fascinating because just as you showed that carb introduction in the setting of a lean mass hyperresponsive phenotype can rapidly decrease LDL. Over a 14-day period of time, there was a 71% reduction in mixed LDL cholesterol. And it wasn't something that took a while to see. I mean, he had several different labs performed during that period of time, and it came down smartly. At 14 days, the question was, is this real? And he even checked it again at 15 and 16 days to ensure that this was a real phenomenology. It wasn't just a lab quirk. And so, just as you had seen in your experiment, he saw in his experiment that carbohydrate reintroduction can robustly and rapidly reduce LDL cholesterol, in his case by 71%. Now, what happened with the statin? Now, you would expect 20 milligrams of rosuvastatin to give a 45 to 50% reduction in LDL cholesterol. Now, everybody's different, but there's a lot of literature out there where you can have an expected response. In Nick's case, it went down about 30%. And so you can take away from that a couple of things. Number one, statins did reduce LDL cholesterol, but not by the magnitude that you saw with carbohydrate reintroduction. Carbohydrate reintroduction was more than twice as robust at lowering the LDL cholesterol, and in a relatively, a very short period of time, 14 days. And secondly, you can look at that 30% reduction in LDL cholesterol and say, is there more to the story, right? Is there a reason that it wasn't 45 or 50% as might be expected just based on population data?
So, of course, the very first thing I want to say that I think all three of us would agree on is this was a demonstration. It's to test principles of the lipid energy model, but we definitely wouldn't want anyone to come away with, oh, so I should instead consume Oreos instead of a statin as a means of lowering LDL cholesterol.
Right.
This was a very specific context. Again, as you mentioned, Nick is not only a lean mass hyperresponder, but if you come into our literature, you'll find that this tends to be with people who are metabolically healthy and who can typically be in this context of where we posit they are fat adapted. And therefore, we're testing this specific context to see how it compares. So as always, as you'll hear me say a million times over, please continue to work with your doctor for your individual care. Now, that said, yes, as with Nick, I was very excited for this experiment because I was predicting much the same results, except that the statin arm was his idea, his intervention. I myself have not, I've not done any interventions with pharmacotherapy, and I was impressed that he was willing to go 6 weeks. It's worth emphasizing that while I'm well known for a lot of my N1 experiments, this experiment that he did took 5 months. And I really applaud him for that because it's a lot of dedication and he really deserves the applause that certainly I'm going to extend him for making this thing happen. But that said, it really did help to further provide data that we could consider when trying to best understand how not only does this phenotype arise, but what is it that can be done if the concern is there, while we continue to get our research on the other end with, for example, Lundquist and so forth, on whether or not this is a problematic phenotype.
So a couple of thoughts. There's an element to this we've called lean mass hyperresponder. And although the phenotype doesn't have a criterion for leanness in it, we know from a variety of data that the leaner the individual, the greater the LDL cholesterol excursion in most cases. And so there clearly is a linkage between leanness in the context of a ketogenic diet, low carb diet, and the magnitude of LDL increase that might occur. And so this kind of goes back to some underlying principles of what may be going on physiologically and why I think the lipid energy model has a lot to contribute to the conversation. So if you're talking about somebody who's pretty lean, let's say a BMI well below 25, even below 20, right? Somebody who's working out a lot, whose overall physiology is such that they are challenged to store a lot of carbs, challenged to store a lot of glycogen. These are folks who have, really, gone to a type of physiology that many people don't see that often. I mean, the type of people we see in our clinic are more insulin resistant, centrally obese. So they're the antithesis of this. So how many times we actually get to see folks who, by virtue of their diet and lifestyle, have attained and maintained a very lean and healthy phenotype, and at the same time have chosen for various reasons to be on a ketogenic diet that is, in many cases, pretty restrictive in carbohydrates, well less than 30 grams a day. Okay, so now we have set up a unique experiment in a unique population that at least I had not come in contact with that much in my clinical practice. You just don't see these people as a clinician that often, right? So as a result, you have to kind of change your mindset into thinking, what would it look like for somebody to be that person and still be able to meet all their energy needs physiologically, not just for day-to-day activities, but for those who are physically active as well. And the idea of fat adaptation is one in which you're basically changing your energy substrate primarily from glucose to fatty acids. All right, well, that makes sense where the fatty acids coming from. And this is where, things get kind of interesting as well. We typically have lots and lots of calories stored in adipose tissue. And most of us have many, many days of reserve, more than we need at any moment in time. But what if you are in this lean adapted state and you are now burning energy in a way that as you are consuming fat, it's got to be trafficked such that it's contributing to lots of your energy demands, not to your storage demands. Right now, when we're trying to store, we're trying to burn. Now, that's a different model. And we have some things in lipidology that kind of mimic that. But at the same time, the question is, if we are really hard, using those energies that we're consuming immediately, we need them. We need them now. I don't have a lot of reserve to tap into. Then that's going to require the body to do things physiologically in a different way, where we're going to have to traffic these things so they're not just available, but they're driving our energy, right? And so I think these are the nuances in the lipid energy model that, while we're still trying to find ways to test some of the steps to make sure that if we can get them, very detailed radio tagged lipoprotein turnover information, which would be great to have. In the absence of that, it's cogent to think that if I'm driving my energy needs through export of VLDL and triglycerides from the liver, and I'm able to quickly take the triglyceride out with lipoprotein lipase and quickly use that energy as the body needs, then would that be a switch that could turn off quickly if I simply change the substrate to having lots of carbs now? Now I have a lot of carbs available. I didn't have that before, but now I do. And part of that is going to be, well, I can burn it, but part of that's also going to be that I can replete stores that would be depleted. And if I'm repleting stores, then will there be the same need for me to massively increase my VLDL production and export to fuel my energy needs? Maybe not. All right, well, if this is a toggle, how quickly can this toggle come on and come off? In your case, it was over a matter of 7 days. In Nick's case, similarly, in a very short period of time, the body is adapting. And if you think about it, that shouldn't surprise us so much. We find ourselves physiologically needing to adapt very quickly to various situations. What happens if you're in a plane crash and you're stranded somewhere and you don't have food available? Your body has to adapt to use its energy stores, so that you can make it till you find a meal. What if you're one of these hunter-gatherer societies? A meal's not promised to you today. You may eat today and not eat for 3 days, and you eat again, right? So we have to have a way to, within certain parameters, utilize energy dynamically, and perhaps more dynamically in lipoproteins than we previously had thought. Again, because we take kind of a long view of things. We have our pathways, and VLDL is a triglyceride-rich particle that comes out of the liver. It gets acted on by lipoprotein lipase. The triglyceride is hydrolyzed and used for energy. The particle shrinks in size into an LDL class particle, which is then subsequently cleared. And that's kind of what we all know. Working around the edges of that, though, is the idea, well, how rapidly can you increase VLDL production? And how rapidly can you increase lipoprotein lipase activity? And if you could increase lipoprotein lipase activity a lot, could you rapidly deplete VLDL particles in such a way that you're now left with a boatload of LDL particles in a faster time frame than you would have expected, and now your body has to do something with it, and that something's called clearance. So how do we clear LDL particles? Through LDL receptors. An LDL receptor binds a particle, pulls it out of the blood, goes back and does it again. That's the process. Well, can you overwhelm that process? Can you have so many particles that these receptors aren't keeping up? Yes, you can do that. But the common model we have is that the receptor gets injured or is in some way not functional as it should be, and we end up clearing poorly. So the model we have in our working lexicon is FH, where people have an LDL receptor axis disorder of any number of types, 2,000 different defects and counting. And at the end of the day, I just can't bind and clear particles very well. So my problem is a lack of sufficiently functional LDL receptors in a number that could keep up with my needs. So that's what we think of as LDL receptors that either don't work well, low in number, or both. Well, that's not this. This is something else. This is lots of LDL particles. We haven't necessarily done anything to the LDL receptor. And left to our imagination is, well, what else could be going on that might influence LDL levels outside of just VLDL? And this gets into a lot of what ifs that I don't have the data for, but just what ifs. What if in the process of taking lots of energy in the form of fats into our cells, we were to downregulate LDL receptors? There is a little bit of data for that with saturated fat, but not for necessarily total fat or others. But there are models out there where you can downregulate LDL receptors in certain ways. Okay, so maybe that's downregulated. Maybe we're increasing cholesterol absorption from our gut. We're a hyper absorber. And because we're absorbing many more sterols, we are overwhelming basically the ability of the system to maintain an adequate LDL response, because we know that if we decrease cholesterol absorption, we increase the number of LDL receptors. The converse is, if I increase lots of absorption, I can downregulate LDL receptors. So maybe that's part of it. Maybe it's just my LDL receptors, unless somebody comes along to give me a hand, are not going to keep up because we're just overwhelming them with substrate and VLDL derived LDL particles. All of these are possibilities. And the reason I raise it is that, Nick's response to statins wasn't so great. A 30% response to rosuvastatin 20 milligrams isn't really the norm. It's a little less than you would expect. Now, that could just be Nick's physiology. That could be some other process that's affecting LDL receptors, just a thought. Or maybe it's just the fact, no, you just can't keep up. Your receptors are trying as best they can, but we have now overwhelmed them. There are so many particles being produced that the production axis is actually driving the LDL, and it's less about the receptor, more about the production. So all of those things are elements that we have yet to figure out, elements that still require some more work and research. But clearly the lipid energy model would anticipate both a rapid ability for this phenotype to improve with carbohydrate reintroduction, and it did, much quicker than you would have expected, and probably quicker than you can expect an LDL receptor response, because LDL receptors aren't going to change in 7 days. They'll change over a period of time, but I'm not aware of data that say that I can take LDL receptors and rapidly increase them in 7 days. And that's what it would take. 70% reduction in LDL with carbohydrate reintroduction. If that was due to an LDL receptor issue by itself, that'd be very hard to explain. I think the lipid energy model does a better job of explaining that. It may not have all the details. We still have things to work on. But again, these are, I think we should keep an open mind as to ways in which, under certain circumstances, lean individuals who possibly have very limited carbohydrate stores, or eating a keto diet with very low carbohydrates to begin with. That's our test population. We don't see that often. And then we have a model which could be much more dynamic than we previously thought, that is very responsive to carbohydrate reintroduction. And now we see effects that we would not necessarily have been able to explain easily through a more traditional way.
Bill, you have to know that this is such a cathartic moment for me because we've been chatting about the lipid energy model for a long time, and you quite literally, it sounds as if you're now ticking the boxes, almost all the boxes. Am I correct in that you yourself feel much stronger that the lipid energy model does indeed have legs in the physiology we're talking about?
Well, yeah, I think what I didn't, and I'm still struggling with this, what I don't understand really are some of the kinetics involved. And really, remember in our previous conversation, my question was how quickly can you? And that really, I think, is the point that has caused me to take a little bit of a longer path to get to the point that I'm thinking that this has more legs than I first thought. And because unless things can rapidly be augmented, it's going to be a hard model to try to explain the majority of the phenotype that you're seeing, right? But if it is the case that lipoprotein lipase can be rapidly turned on, can rapidly delipidate a VLDL particle, take the triglyceride out rapidly. And so now we are rapidly transitioning into these LDL particles that have to be handled. That to me was one of the critical questions of how much do we think the lipid energy model is a part of the process, a large part of the process, a dominant part of the process. There, I'm sure, are other things, but we just haven't had that many times where there have been physiologic examples of folks like lean mass hyperresponders and Nick specifically, who could go through a thoughtful experiment, a thoughtful process, and say, if the lipid energy model on its face is as we described, then we would expect to see robust, rapid changes that would be difficult to explain in other ways. I think that's a fair statement. And that's where I'm at. I'm at a loss for alternative explanations that would equally mimic the data collected. So I think as a working hypothesis, though it's novel and though it requires a bit of rethinking, it's reasonable to consider that that is as part of the explanation, if not a large part of the explanation.
That's great. And for what it's worth, I mean, I can get a bit, let's go ahead and get a little geekier here. I think in my case, and I'm not speaking to Nick's, but in particular in my case with my experiment, I believe a big part of why the LDL could go down that much further, that much faster, is in large part from adipocytes or fat cells. My fat cells, I believe, were not just taking up more of the lipids, but in fact, the lipoproteins themselves. I think that there's more endocytosis on adipocytes in a period of abundance where you literally are expanding to accommodate the additional contents. And we don't really know what that gradient is because we're not usually studying healthy populations. I wish we would. I wish we'd study more healthy populations, especially in the fat adapted context. And in time, I think we will, to be able to know these kinds of things. But part of what I especially love about Nick's experiment in comparison to mine is that his was just a straight addition. So for folks who might say with mine, oh, well, you probably reduced saturated fat. And in reducing saturated fat, that explains why there'd be less LDL. His was a straight addition. It was literally hypercaloric, as in he was consuming more. So I think there's both the potential that there was more that could be impacted on that end, as far as like the storage component goes. But on top of that, it helps to answer that question on the saturated fat. He didn't have a reduction in saturated fat. In fact, I think the Oreos themselves had a little bit of saturated fat in them as well.
Yeah.
But the dynamic aspect of the physiology, that already has been a very difficult thing to sell, particularly to many of the colleagues in your field, because a lot of it is assumed to be more of a positive feedback loop, that there's a lack of binding, and therefore with this sort of rate limitation, things will keep going up and up and up and so forth. Now, that the thing that I want to zero in on that you're doing that no lipidologist to date has ever explained back with the lipid energy model, that's one of the most controversial pieces, but that I want everybody who is tuning in to understand, is you're explaining a crucial component to the lipid energy model, that there's actually a net increase of triglycerides leaving the liver on purpose, that there's a higher recirculation, which can explain why there's more of the VLDL that carries it, and alongside, coupled with the faster turnover, resulting in the higher low density lipoproteins and therefore the higher LDL cholesterol. The higher triglyceride export, again, we only typically see in populations that tend to have a greater level of illness because they have more de novo lipogenesis. Their livers are overproducing. Whereas in this case, we're positing that there's more recirculating of existing fatty acids to power somebody who is not only metabolically healthy, but is typically leaner and might have a reason to be exporting them at a faster and faster rate. And that's what we think is happening with Nick. That's what we think is happening with many of us who have the triad, such that when we do something like what Nick is doing, or something like I was doing, we actually see this pronounced change that quickly.
But at the same time, though, we do have a working model where non-esterified free fatty acids in the portal circulation hitting the liver have one of three fates. You either get burned beta oxidation, you get processed into lipid and exported into VLDL, or you become resident in the liver tissue, steatosis. So if non-esterified free fatty acid flux into the liver
also
drives,
sorry, or ketogenesis as well, of course.
Right. Yeah. So this is kind of the comparison contrast, right? So what do we kind of know from a disease model? What do we kind of know from the normal lipidology way? It's non-esterified free fatty acids hit the portal circulation, and what I just explained occurs. Well, is there another way to get there, right? And so if you can get there another way, once you are flooding free fatty acids into the portal circulation, the same three fates are available to you. You either burn it, it becomes resident in the tissue, or you increase export of VLDL. So really, that's the linkage between what we would consider to be kind of tried and true physiology. But the caveat is now I am saturating the portal circulation with free fatty acids, not due to mechanisms such as our insulin resistance, but through a totally different mechanism.
So I do want to recall then, with regard to where you stand right now with the lipid energy model. I remember the first time that you were talking about lean mass hyperresponders. It was actually on Rob Wolf's show, a mutual friend of ours, of course, and who you've known Rob forever. You at that time were speculating that whether it was in or outside the lipid energy model, this was likely a disordered lipid metabolism. Do you think lean mass hyperresponders have a disordered lipid metabolism?
So let me back up and tell you where my mind was at when I made that statement. So if we are looking for an explanation for the phenotype, and we're thinking that there can be an LDL receptor axis in some way involved in this, then that is the disordering. It is some sort of change in the LDL receptor axis. That's the disordered, dysregulatory part that I was speaking to. Now, one thing we do know about the LDL receptor axis is it's very dynamic as well. If you look at a PCSK9 inhibitor, for example, if I were to give you an injection of PCSK9 inhibitor, and its job, as your viewers know, is to reduce or actually remove PCSK9 from the circulation. This is a chaperone protein which binds to LDL receptors and limits how many times it can recycle. So the LDL receptor isn't just a one and done thing. It grabs and it recycles many, many, many times in its normal life until something tells it you can't do that anymore. And that chaperone protein that prevents recycling is PCSK9. So if you were to receive a monoclonal antibody that binds avidly to PCSK9, so much so that 4 hours after an injection, you have no detectable circulating PCSK9, which is true of our currently available agents. You can do some kinetic studies that have been done, and within 4 days, you have dropped your LDL massively. And it's very durable. So that is the most rapid axis induction that I have seen, is by just taking the regulator plate off the engine, letting those LDL receptors just go, 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 go with nobody telling them to stop, right? So that is an example of something that can occur very rapidly. On the other hand, we don't know of things that have the same magnitude or speed of downregulating LDL receptor axis function. So my thought when I was speaking on Rob's podcast is, for various reasons, I think the LDL receptor axis is important. I think the LDL receptor axis could be part of the reason why LDL elevations occur in a kind of a longer term lean mass hyperresponsive physiology. And if the LDL axis is somehow perturbed, that would be a dysregulated state. And so that's what that term was meant to imply, but I don't think I got that point across. Now, outside of any potential LDL receptor axis disorder, I don't think I don't think lipid energy model is an example of dysregulated lipid physiology, right? I think it is an adaptive physiology, but adaptation and dysregulation, I think, are two different things. Adaptation is what the name implies. We're adapting to meet energy demands the body has to have. Dysregulated is one in which I have a normal physiology, which is now no longer able to do its normal thing. I can't make my LDL receptors by function, by number, by recycling, maintain their normal jobs, if you will, their normal role, right? So if that were part of the scenario where the LDL receptor axis was challenged, that would be a dysregulated state. I leave open the idea that there can be a LDL receptor component to this discussion. We don't have data to unpack that yet. It wouldn't shock me if we found it, but I don't think that the LDL receptor axis would be a compelling model to explain the data as we have it in hand without having the lipid energy model as the basis. And you might add this to it as part of it. So I guess that's where my thinking has transitioned, is from how rapidly can lipoprotein lipase really turn on? How much can we really overproduce VLDL and have this plethora of LDL that just overwhelms my otherwise normal LDL receptor axis? That's novel. That's not something I've encountered. That's not something that I've seen. That's not something I treat. I hear it. I have never experienced it. So we'll keep an open mind. But from my experience, that sounds like we have some work to do. On the other hand, I treat LDL axis disorders all the time. That's my bread and butter as a lipidologist. I encounter people who, for any number of reasons, they have a clearance issue and they need clearance help. The production issues I see in lipidology are almost always tethered to insulin resistance, metabolic syndrome, that type of dysregulated physiology, right? So to have another explanation where, no, I'm just going to take an otherwise healthy person, I'm going to put them into a situation where over time they become lean, perhaps glycogen depleted, glucose storage depleted. We're going to feed them mostly fat and very little carbs. And we're going to see what happens to their physiology. And if the lipid energy model is an explanation for the data, you would expect that reintroduction of carbs in some manner would largely ameliorate that.
Which is what we've seen. I mean, that's what's
That's right. So at the end of the day, you say, well, isn't that interesting? So I continue to transition. I let data inform me. I try to, right? But it does take a little time sometimes. You have to start with the models that you feel most comfortable with, that you have the most data for, that you've used over 30 years. And, you've got to, try on for size some other, and, there are some models out there that have come and gone and didn't stick, and that's fine. But we are still learning, and there are still novel opportunities, either by virtue of the patient or by virtue of other factors. And to your point, we have not had a very organized effort to understand folks who are very lean, who are on a ketogenic diet with low carb intake, who have a lean mass hyperresponder phenotype, and then in a very orderly way try to pick apart the physiology involved, pick apart mechanistically what may be involved, pick apart what therapeutics might or might not be helpful and why. And we're beginning to get there. We're beginning to piece those things together. And I think that's a credit to you and Nick and many others that have said, this is worthy of, more thoughtful efforts.
I've made the prediction for a long time. Nick, Adrian, we all agree, and I'm picking up that you probably agree as well. I predict the lean mass hyperresponder phenotype will actually teach us a whole new frontier of lipidology. I just genuinely feel like there's already so much that we've seen thus far. Do you agree?
I think it could. I think it could help us in several ways. Number one, I think just the understanding of how dynamic lipid physiology, lipoprotein physiology is, how quickly can the body adapt, change for various reasons. You don't get that impression from your third-year medical school lecture on lipoprotein metabolism. You don't get that impression from having people come to your clinic with high LDL cholesterol and you told them to do something with their therapeutic lifestyle they didn't do. And now you're left with trying to make it go down with a pill. You don't get this idea that things are very, very dynamic and adaptive. So you have to find models in people for whom this is a real thing. And then you have to, open your mind to the fact that maybe there are additional factors going on that don't really get fully explained by what the conventional wisdom is. So in that way, number one, it's going to help us. It's going to help expand our understanding of lipoprotein physiology. Secondly, it's going to help us, I believe, in something that's very important to me, and that is the time dependency of potential injurious effects of atherogenic lipoproteins. And you and I have talked about this a lot. And this is something that I've said for many, many, many years. The calculus for risk is how bad for how long. The calculus for benefit is how good for how long. And how long is the thing that never gets discussed, right? We do these studies in populations where you have a baseline data set and you infer based on the baseline data you have, that's what that person has been for a very long period of time. That may or may not be true. My experience in the clinic is somebody comes to me with abnormal lipoprotein values. My first question is, how long has it been this way? And many times people say, you're the first person to ever ask me that. I'll give you a quick example. A 70-plus-year-old lady came to me and she said, I want you to tell me I don't need a statin. I said, well, who told you you needed a statin? Well, my primary care doctor. Well, why did he say you needed a statin? Look at my labs, LDL cholesterol 210. How long has it been that way? You're the first person to ask me that. She pulls a binder out. Flip, 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 flip. 5 years ago, it went up. Prior to that, it had been fine. And so now my interest peaks. I said, well, there are reasons why things change over time. And we went through the whole workup. She had hypothyroidism that had not been identified or managed. I said, okay, so at least from what you're showing me, I think this is a recent problem, high LDL. You haven't had it for a long time. And in the world I live in, how high for how long is very important. So it could be that maybe your arteries look great. Maybe you have arteries that don't need to be treated. So get a CAC score, 0. A 0 coronary calcium score. I said, per the guidelines, at your age, a 0 calcium score makes statins optional for 5 years. And she said, thank you very much. And she was happy as a clam when she left. But 3 things came out of that. Number 1, how long? Number 2, is there end organ evidence of disease? Right? So these are things that sometimes don't get discussed enough. And then if you don't have any end organ evidence, check again somewhere down the road, right? Things can change. And the guidelines, in my opinion, at least over the past 5 to 10 years, have put a premium on knowing more than just your lipids. They've put a premium on integrating your clinical history, risk-enhancing factors, imaging studies, more advanced tests to get a better picture of who is this person who has an LDL of whatever, okay? And that's really what you have said a lot as well, and that is, who are these people? What's going on with these people? It may be that these people, to first inspection, look much better than you would have expected. Maybe we don't see evidence of plaque in their vessels, in which case, what would you do? Well, you have several options. Option one is you can do nothing. Option two is you could try to lower punitive risk factors because it's what you do. You could follow them over time with some sort of sensitive imaging technology that could detect a change over time. Those are all options, but left to your imagination is what's the expectation in the first place? Do we expect these people to have plaque? If we expect them to have plaque, how much plaque? How quickly should plaque be changing over time? Are there reasons that mitigate that beyond just what we see in front of us? Right, so this is all important stuff, and I do. I don't like to be a reductionist all the time by any means, but I do believe you can do a little reductionism here by saying, is there plaque? I mean, if you have plaque in your vessels, that to me is a different conversation than people who are free of disease. If you're free of disease, you're free of disease. That's a different conversation. You have plaque, something has turned on that we don't want to get worse. And that's where I think I am in my rights to talk to somebody and say, listen, don't smoke, exercise, eat healthy, have a reasonable body weight, don't have punitive risk factors that go unchecked, which means you're not going to be hypertensive and let it go unchecked. Don't be diabetic and let it go unchecked. Don't have a super high ApoB and let it go unchecked. These are bad ideas. These can fuel existing disease. And so we start the conversation, you have disease. Now, what are we going to do about it? If you don't have any evidence of disease, that's a different conversation. And I'm open to the idea, just like in this lady who comes to me with a 210 LDL cholesterol that seems to have only been for a few years. She had no evidence of plaque, at least by CAC score, which isn't the most sensitive, but at least by CAC score. Similarly, let's take lean mass hyperresponders. They have a high LDL cholesterol. They come in and they get imaged. Some may have plaque, some may not have plaque. What do you tell them? Do you have the same message for everybody? No. Would you tell the people who have plaque we need to have a different conversation than the people who have no plaque? I think so.
So this is good timing in a sense, because as you know, we're doing the study out of Lundquist by our mutual friend, Dr. Matt Budoff. By the way, when last we chatted, you said to pass off a hi to Dr. Budoff, and I did, and he passed the hi back. So I can tell you that here on camera. We, of course, are especially interested and always were for the subgroup of whatever that population was going to be in our existing lean mass hyperresponder cohort. And to not just look at the presentation of plaque that might come at baseline, but for that group, the progression, which is why it's a longitudinal study. So for those who in their first scan had any amount of plaque, even if it's a low amount, how much did that increase at a population level within that population? It's worth emphasizing that. And for those who aren't as geeky and into this conversation, you and I will both bring up the example of like the smoker who smoked 3 packs a day their whole life and they didn't get lung cancer is not proof that smoking doesn't cause lung cancer. In the same way, if we have one person who has very high LDL and they have a low plaque score and it doesn't move or something, that's not in and of itself something that can be taken out of context. We're interested in the population. So our endpoint of interest is non-calcified plaque volume at a population level. Does our whole cohort show an increase in non-calcified plaque? And of course, we're going to be especially interested in this group, as you were kind of bringing up now. If somebody does have if they're like, say, Nick, and they have LDL that's hovering around 400, 500, but they have no existing plaque as indicated by CT angiography, as you said, that's a different conversation you would have than somebody who did have plaque. And my guess is you would say this regardless of whether they had a small amount of plaque or a large amount of plaque. The only difference is the level of urgency you would probably push forward. But if you say, for example, connected with somebody who had a CAC of, let's say, 10, and they were age 75, right? So they have some amount of calcification. At 75, that might be low, but there's still some amount of calcification. They're a lean mass hyperresponder. They have an LDL of 400. You yourself would still feel like they should take action to lower their LDL. Would that be correct?
With a caveat, yes. So you said a couple of things that I want to just touch on there. Number one is when we have a number other than zero, we want to put context around it. And one way to put context around it is by adjusting the raw number by age, gender, and ethnicity. And so MESA does this. There's a MESA calculator that's available online to anybody. And it takes into account, your ethnicity, your sex, your age, and says, okay, a 10 at 75 is something very low from a population percentile perspective. It's low. 10 in a 40-year-old is different, right? So now we have two different points of reference. Do we expect some amount of plaque can occur in an otherwise healthy aging population? Yes. Okay, so as a consequence of aging, some atherosclerosis occurs. We used to call this hardening of the arteries, right? Old people get hardening of the arteries. So you have to be able to expect that somebody somewhere along the line has a number other than zero. So a number other than zero does not necessarily, to me, mean that there's great urgency to go right around it. Okay, I do think you have to put context around it. So how old are you? What else is going on? What percentile does this represent? Is this our first look? Is this longitudinal over time? Has it changed over time? All of these are important things to look at. Now, would I still feel comfortable with somebody staying at 400 with any amount of plaque? No, I just wouldn't. Why? Because we believe ApoB-containing lipoproteins feed plaque development. All right, so if that's part of the calculus, don't give the plaque things to eat. If I just take it down, there's less substrate to get into plaque, and potentially that could be helpful. So, first do no harm. It's one of the first things we think of in medicine. What's the worst thing that could happen? Worst thing could happen is I leave somebody at a 400 with some small amount of plaque, and they worsen because I did not take steps to ameliorate a punitive risk factor. Okay, so I would default into that's not a safe place for you to stay for a long time. We need to bring that down. That would be and for that reason. On the other hand, give you an example of a guy who came to me in his 20s, and he says, I'm here for you to tell me my arteries are fine. Why would you have that question? Dad had event at 35. His grandfather had an event before 40. His paternal uncle had an event before 40. He has FH. He happened to see a colleague of mine in another city had a coronary artery calcium score that was high in his 20s. And he wanted me to tell him his arteries were okay. Well, no, that's fear speaking, right? He's just in denial, that nice river in Africa. I have no problem here. And so the urgency was clear. All right. So you have this physiology, you have this terrible family history, you have abnormal plaque by a lot for your age. Dude, we need to pull every lever available to us to slow this freight train down before it crashes into you. All right. So there's the urgency at an extreme. And then at another is we need to take care of that. But is it right now as low as I can get it or else? Right. So these are the artistic aspects of medicine that we all have to grapple with. And every good clinician I know thinks similarly of, what's going to happen if I leave this person the way I find them. That's the way you start the conversation in your mind and as you're having a conversation with the patient. If you believe, based on your best knowledge, that leaving them the way you find them is harmful, then finding some path forward that's different than the way they present it to you is critical. It doesn't mean you have to pull the biggest gun out of your toolkit right away, but you can't leave them there because the consequence of leaving them there would be unacceptable. Now, does treating anybody give them a guarantee of success? Absolutely not. There is no guarantee for success. So in my fellowship, my mentor asked us one time, gentlemen, who's a good candidate for medical therapy? And his answer was, what happens if you don't do anything? It's not doing anything that gives you the reason to want to do something different, because not doing anything has a high likelihood of something bad happening. And the more that is the end of the patient's presentation, the more urgency you have. And the less that is the end point of the patient's presentation, the less urgency you have. That doesn't mean that you're going to ignore things, but I do think you have to have that sort of context in one way or another that you build around the individual.
I think it poses a challenge in this case, though, because among your colleagues, there's a very wide spectrum of opinion on LDL's independent contribution towards atherosclerosis. And I should emphasize, by the way, that I consider you a moderate. You're not an end all be all, which is part of why you bring up not only the relevance of whether or not there's physical disease detectable with a CT angiogram or a CAC. But on top of that, your own platform, which we'll talk about at the end, really cares a lot about all of these different vectors and trying to composite them together to best assess risk, not leaning on any particular marker. But a lot of your colleagues do, where they feel that pretty much everything can come down to the common driving factor of ApoB lipoproteins. But you wouldn't say that for you. I mean, let me put it this way. If you had to give it a percentage at a population level, how much do ApoB lipoproteins independently contribute to the process of atherosclerosis?
So I'll not give you a number because I don't know exactly how I would come up with that number in a population context due to a lot of confounding variables. What I would say is there's another way to come to the conclusion that ApoB is important, but not all-encompassing. And here's an example. If we believe that ApoB-containing lipoproteins are the only reasonable way to decrease future events, then we would look at studies where people are being treated in various ways and say, well, how much improvement am I getting by lowering radically ApoB? One example would be Fourier. The Fourier study is 27,000 people. Everybody has disease and risk factors. Half get statin placebo, half get statin Repatha. Okay? There's a marked reduction in events in a short period of time. Well, that's great. Did they still have events anyway? Yes. There were still people who were having events in the more aggressively treated group. All right, so we have not ameliorated and wiped out events. We've improved them. We haven't wiped them out. Okay, that's one point of reference. Another point of reference, if we look at the REDUCE study, now this was a trial of individuals who either had diabetes and multiple risk factors or known atherosclerotic cardiovascular disease. They were all on state-of-the-art care, including statin therapy, including ACE inhibitors, beta blockers, etc. They had well-managed LDL cholesterol, but they had triglyceride 150 and higher. These individuals randomized to get 4 grams of pure EPA versus placebo added to their statin. And they had a marked reduction in heart attack, stroke, cardiovascular death in a very short period of time, and had a number needed to treat for any event that was less than 10. Now, how do I take those 2 points of reference and bring them together if I don't acknowledge that there's more going on than just the number of ApoB-containing lipoproteins? See, so this is the way I think that you can look at the totality of data and realize don't do the bad things, do the good things. There are 2 different things in play here, okay? Don't continue to hit your hammer with a thumb, bam, bam, bam. But that's not the only thing that's going to make you feel better. Don't hit your hammer with a thumb. I guess, we are learning more and more, and directly as well as indirectly, the Oreo experiment, the lean mass hyperresponder data, the imaging data that Matt has led and will continue to add to are new learnings that have to be layered on top of the totality of data, where at the end of the day, we say it is advantageous to not have increased numbers of ApoB-containing lipoproteins. And I'm an ApoB guy, have been for years and years. I'm not going to walk away from that, but I am going to put context around it. It is true that if I radically lower my ApoB, I can look at Huygens data. using optimal tomography, imaging of lesions from inside the vessel. And I can tell you in 50 weeks, if you compare individuals with a statin and an LDL cholesterol of about 90 versus statin Repatha and an LDL cholesterol of about 30, there is much, much better thickening of the fibrous cap, much less lipid in the wall of the artery. We have lots of data to suggest that we can stabilize and regress plaque in part by how aggressively we lower LDL, yes. But the Cherry data would also say that if we add EPA to a statin, we can also get plaque improvement through totally unrelated means due to things like decreased lipoprotein oxidation, decreased foam cell formation, decreased fibrous cap rupture, all sorts of things that are not mediated by the number of ApoB-containing lipoproteins. So I think if we're going to be honest and we're going to let all this data speak to us, we have to have a very inclusive understanding of how our patients can get in trouble, as well as whether our patient is in trouble when one thing is out of bounds, but it's not telling us the whole story.
There is a bit of a challenge, I think, though. And in fact, it's a part of why I really wanted to do the study that we're doing now. Up until this point in time, we've not gotten prospective data on people with extremely high LDL cholesterol that didn't have some form of a dysfunction or illness or baseline inflammation. I think that you've probably heard the analogy that you're usually looking for your keys where the light is the brightest, that comic that constantly gets reused. I think I can understand that to an extent, and this kind of brings us back to Brown and Goldstein. Brown and Goldstein, when they were looking at children with homozygous FH, it was regularly said, this is probably the strongest data yet for the lipid hypothesis because these children had both sky-high LDL and ApoB alongside very rapidly developing cardiovascular disease. But as I've said many times over, I think that there's still a dysfunction in lipid metabolism that's relevant in this case, as Nick would say, that's broken. And I think that that's kind of important. We needed to come into a population like lean mass hyperresponders who we posit may have a functional lipid metabolism and actually check to see if this risk converts. Are people with comparable levels to homozygous FH, Nick is one such example, are they going to have the same rapid development of atherosclerosis that we see with the patients of Brown and Goldstein? We just didn't have this kind of data until now, which is what we're looking at with the existing Lundquist study. What do you think?
So there are a couple of interesting points to that, right? Just to unpack a couple of things. We have some new tools that, again, let time be a variable more so than we have previously thought. Mendelian randomization studies, okay? And it's just a tool. It's not an end-all, be-all, but it basically says we know the human genome. We know that there are various genetic factors that are associated with various things. And you can ask questions from this knowledge. You can say, if you have lifelong low LDL levels, what happens to your rates of cardiovascular disease? If you have lifelong high LDL levels, what happens? And so from Mendelian randomization data, as well as experiments of nature, we do see that change over time can be understood in different ways. So to your point, you can have a very high LDL from birth, homozygous FH, and in a short period of time, those people get into some real trouble. You can have a more modest heterozygous FH or polygenetic high LDL. If manifested for a long period of time, that can also be consequential. But it has to be a lot longer because it takes much, much more exposure to end up with plaque in that model. So the model is that the quantity over time is the concept. Now, what's curious is if you take the PCSK9 deficiency experiment, the way that we came up with this class of medicines, PCSK9 inhibitors, was by identifying a cohort of individuals with low LDL for a lifetime who had very, very low ASCVD events. And they're just missing this enzyme that we attack with Repatha or Praluent. Okay, so what did they do? They just allow their LDL receptors to go ad nauseum with nobody telling them to stop. That's a supranormal physiologic approach. Nothing's broken there necessarily, other than they're just using lots of recirculation of LDL receptors to maintain a low ApoB and LDL level over time. And they have very few events. Now, these people also, in large numbers, could have other things going on, but just again, the idea that maintaining low LDL over time has fewer events associated than high LDL over time. I think that's a safe statement with lots of caveats to go around it. So the question that you're asking is how much time? And I guess, I've teased you a little bit in some conversations of as, we're looking at this longitudinal data with CTA. My question is, how long does it take to develop disease? Not whether disease develops, right? So that's consistent with my thinking is baseline, similar to other folks who have had it for a lot longer, interesting. But over time, how long does it take for this physiology? And the answer could be never. That's an answer. It takes a really, really long time, much longer than you ever expected, which means that there are factors which blunt the impact of ApoB in a favorable way that we hadn't really been able to apportion until then. Or it could be that, it's not as bad as some, but it's certainly no walk in the park, and these guys got to be careful. And that's why, to me, the longitudinal data is going to be really, really illustrative to us. We don't know the answer. We don't know the answer. If you're an ApoB rules the world guy, you're just waiting for them to fall off the cliff, right? If you're a guy who says ApoB is causal but insufficient, then this may be a group which has lots going for it that's going to dampen that LDL response.
It's part of why I wanted to talk about this before those data are actually in, is because at this moment in time, the present lipid hypothesis, particularly given we have some folks with extremely high levels of LDL, comparable to Nick Norwtiz, would presumably both present with plaque at baseline and would likely show a rapid progression of that plaque. The reason is because unlike the children that Brown and Goldstein were looking at, they have 5 decades of lifelong LDL exposure, which apparently per the baseline data looks like it's about average. You're probably familiar with milligram years. That's a heuristic comparable to pack years. So for people who are not familiar, pack years are when they're trying to give a sense of exposure for, say, smoking cigarettes. And if you're smoking 3 packs a year as opposed to smoking 1 pack, then that adds to the cumulative total. So 3 packs a year for 5 years means 15 pack years. By the same token, with milligram years, it's the same expectation on exposure over time. I think what was the name of the little girl that Brown and Goldstein were examining originally? You actually knew her name.
Yeah.
Is
It's just escaped me.
Oh yeah. And anyway, she had an LDL, if my memory serves, of somewhere around 780. So let's say we round that to 800. By age 3, she had a stable angina. Again, I hate even talking about this because it's just so heartbreaking to know that would happen. But that's milligram years of 2,400 if we round it up to 800. And you'd have about 4,800 when she had her first event, which was at age 6. And this, I think, is part of the basis of where they came up with the number 5,000 milligram years. I'm actually doing this math right now with our cohort, and granted, it's not part of the official study, but you can see the milligram years for both not only our cohort, but this match analysis we'll get a chance to talk about in a moment. So you can actually see what that exposure would be over time, and then add the 4.7 years. That's the average that they've been lean mass hyperresponders even before, even at the baseline scans, to see what the expected level is at a population for what their total plaque score would probably be. Now, I suspect you and I both probably agree on this. Even though it's been 50 years and we want to absolutely give reverence to Brown and Goldstein for their seminal work, I do think there is a difference between monogenetic FH and LDL levels that associate with cardiovascular disease in that context. And everybody else, not even just lean mass hyperresponders. I think there is a relevance to that lipid metabolism beyond just the higher exposure of LDL and ApoB. And I think our data here will be the first of its kind because it's the first that I'm aware of that actually had people that got to those levels without having something like monogenetic FH or very novel polygenetic FH that could like get it to those levels. You being a lipidologist, you could actually confirm whether or not I'm correct on that. Is that probably a correct assumption so far?
Oh, several things. One of the things we don't talk a lot about for FH is that this is occurring in the background of someone who is growing and developing. So the heart is growing and developing. We're growing and developing. Cells are reproducing. Organs are going through change. And then we go through physiologic changes into adulthood. And during all of this time, the response of tissues to super high LDL in those very young years can be very different than the response of tissues in adults who acquire high LDL in their adult physiology. So that's another part of this conversation that often isn't discussed is that, this is not a little adult who got older. This is a child who's going through normal child development in the setting of very high LDL, which does things uniquely differently than a 40-year-old who says, for various reasons, I want to go on a ketogenic diet because it's going to help me with some problem that I'm dealing with. And there are a lot of problems that a ketogenic diet helps with. And there are a lot of reasons why people would want to go on a ketogenic diet, right? So you can say, I have something in my life, I'm going on a ketogenic diet, I'm really lean, I've tried super hard to live well, and now I'm a lean mass hyperresponder. So what you're saying is the clock would change at that point. He's had a certain LDL, and then the LDL went into a different direction. So the pack year exposure would have been this, and now we're adding more to the pack year exposure because now we have this. So the slope has changed. So what would have taken him maybe to age 65 to get to that threshold is now going to take him less time if he stays on this slope, right? So that's kind of the model is that we believe that if this soft, I will emphasize a very soft threshold of milligram years is to be reached, then the quicker you reach it, the sooner you would expect to see plaque, and the longer it takes you to reach that, the perhaps less plaque you might see. And all of us are on some sort of slope. And the inflection point in this conversation is lean mass hyperresponders incited by the ketogenic diet. And so trying to model that is artistic because you don't really, in many cases, know what their slope was to begin with. You know what their slope is once they declare themselves as a lean mass hyperresponder. So then you have a little bit of difficulty trying to add something, unless you have previous data, to what is the new phenotype, right? But outside of that, you're correct. That the longer they stay at a faster slope, the quicker they'll hit that threshold.
But aren't we kind of benefiting by the fact that there is a decent number? I mean, granted, we're not in the thousands, but given that we have 100, we can somewhat speculate a normal distribution. Like there are probably not several standard deviations outside of the central tendency. I know I'm getting into statistics, but I know you know what I'm talking about here. Basically, would it be reasonable to speculate that our population, particularly given they gave us our pre-lean mass hyperresponder phenotype lipid levels, and they happen to have landed like literally right down the line of the central average, that probably they had, as a population, average-ish levels throughout their life? I think that that's a reasonable speculation, at least to the extent to where I doubt it would impact my opinion too substantially to just assume that they might be much lower before they happen to have gotten the lipid panel that just happened to be before they then adopted the low-carb diet. What do you think?
I think with 100 people, that sounds like a lot. It's a really small sample size for a population conversation. And there are a lot of things, just as a lipidologist, I'll tell you that, might surprise you as far as what would impact lipoprotein levels before a lean mass hyperresponder phenotype in response to a ketogenic diet. So, you have to start somewhere. You have to have a model, and you can posit with the model. They had a median LDL cholesterol going in, and then they did this. Okay, that's a model. There's nothing wrong with that. Now, whether or not it's an accurate model, I don't know. Without data, we wouldn't be able to say, but you have to start somewhere. And let's just say, okay, we're going to say median is median, and they're median folks. All right. And if they were median, then you would expect the line to be here. and you expect the line to intersect this threshold line here. And now, for a period of 4 point some odd years, they are on this trajectory. And if they maintained this, then I would expect they would hit this threshold at this time. And that's an exercise. There's nothing wrong with that. Whether or not it, accurately captures that cohort of people, I couldn't say. But as a working hypothesis, you could say, we were less, now we're more, and being more and a lot more, we're going to potentially get to that line quicker.
I think that make no mistake, we're really kind of in the weeds of nuance right now. I know a lot of people watching, and for that matter, a lot of people who follow yourself, myself on X, they're looking for just the hard black and white answer. Can I either fully accept this study as the end all be all and then not like read or watch another study past this point? Or for that matter, can I completely dismiss it and not feel like there's one thing that's kind of a flaw with it that I feel like I can completely toss the data out? And you and I, we're really not even in those zones at all. We're both excited about this data. It's going to build on further data. It's, all of us are accepting that these are the first and initial steps and what may be a really powerful new frontier. Obviously, I'm a little biased when I say that, but that's what's kind of neat about this is until now, we're not actually getting, I mean, we just talked a lot about the mechanistic, but now we can talk about the risk. We're literally getting CT angiograms on folks who have been at these levels for a long time. And I have to tell you, I don't know if I ever got a chance to tell you this publicly or privately. I really didn't know what our baseline numbers were going to be until it really shook out, that they would be in the 200s, the high 200s. And for the span of time it's almost half a decade at these levels, which I like because then I feel as though we're having a pretty powerful first step to be able to better ascertain this data. I don't know about you. I'm very excited to see what the longitudinal scans will show us.
I think to me, that's where the story is. The setup for the story, as I call it, is what we have right now. The setup is we are learning about lean mass hyperresponders, their physiology, their mechanisms. It's not surprising that individuals may take a while to develop plaque if there's a fairly abrupt change in LDL cholesterol. What I'm open to is the fact that for various reasons we still don't understand, I can wrap my head around various data that may come in the future. I can wrap my head around the idea that if we were to follow these people with CT over a long period of time, that there is accumulation of plaque that is greater in those with greater LDL and lesser in those with less LDL, generally speaking. I can wrap my head around the idea that people with existing plaque might change over time differently than people who had no plaque on their baseline CTA. I can wrap my head around that. I can also wrap my head around the fact that in a physiology that we have not seen in large clinical trials represented in our typical types of intervention trials, that some of these individuals may be able to be almost symbiotic with this high LDL and be less diseased than expected over a period of time. And wouldn't that be interesting? Wouldn't it be? Because we go back to a statement you made earlier, the 3-pack-a-day smoker who got away with it, right? And we say, yeah, that's an outlier. 3-pack-a-day smoker got away with it. And I can look at FH patients of mine who are in their 60s. They haven't had an event yet. Did they get away with it? Or is there more going on than simply their LDL? And if that's the case, to what degree is there more going on in the lean mass hyperresponder, which may buffer them a lot in the context of having high LDL? And maybe it's the case that there is an intermediate ground. And the intermediate ground is, and if you had no plaque going in and became a lean mass hyperresponder, man, we might be surprised how long you hang in there before stuff happens. But if you had plaque at baseline and then you became a lean mass hyperresponder, you could behave very different, right? This is all conjecture. I have no idea. I haven't seen the data. You haven't seen it. We haven't generated the data yet. But I can envision all of those possibilities and be very intrigued to see where the data takes us.
I'm gonna kind of walk this into that exact term that you used, buffer, just a little bit further. And I want to put this on the table with extra emphasis that it is strictly a hypothesis. But I do believe this dysfunction in lipid metabolism is a crucial confounder that I don't think gets as much attention as I would like. Now, this isn't to say that I don't think the lipid hypothesis would be entirely invalidated if it proves true, but it's possible that this dysfunction in lipid metabolism that associates with the very real mechanistic component that is plaque development with ApoB lipoproteins can actually be an issue with us being able to detect that true relationship. So let me unpack that a little bit better. In a sense, I think many of us, you, me, Nick, we will say ApoB lipoproteins are causal in the process of atherosclerosis. But that doesn't necessarily give us as much useful information when stated that way. For example, I can also say macrophages are causal in the process of atherosclerosis. If I had a drug that could reduce the differentiation of, VCAM of monocytes into macrophages into your arterial wall, you would predict, as I would, that you'll end up with less plaque. But probably that comes at a trade-off for the immunosuppressants that it is, right? By the same token, we don't know yet what the trade-offs really are and in all the contexts of lowering LDL. You mentioned the PCSK9 loss of function mutation, for example. It's absolutely true. The data show that they tend to have lower incidence of, for example, heart attacks, but they don't actually have greater longevity. They don't live longer. And that's why I've kind of wanted to get into that data. I'm hoping Adrian Sotomoto may actually have something that we're working on soon to better understand what's increasing to offset the change in the actual cardiovascular disease mortality. And that I think is an important question to raise when only looking at this in the context of very small margins of potential benefit. And this isn't to say that we shouldn't ignore the potential benefit, only that we should know if there is a trade-off. And so in the case with lean mass hyperresponders who are on the ketogenic diet for efficacious reasons, they have epilepsy or they have a type 1 diabetes or something, their choice is much more immediate. You could go to them right now and you could say, I know for sure, you'll shave off a month of the end of your life because you'll have a heart attack that much sooner. And I know many who would be like, I'll take that right now. I'll take 5 months. I don't care if I can have less seizures today, right? But that's a question we're not going to be able to answer very easily with our study. And I said that in the announcement of the study. We can answer the big magnitude question pretty quickly. Do lean mass hyperresponders with an LDL and NICS range of 400, 500, are they developing atherosclerosis very quickly? And if they aren't at a population level, I expect that many like yourself will say that might be true, but probably on net, they'll have a higher relative amount of plaque progression at a population level than if they had everything else kept the same, but their LDL was lower. Does that make sense?
It does. And I smiled in the middle of that because you're aware that as a side area of interest for many, many years has been the question of mortality. And is mortality an endpoint which we understand well? Is mortality something that is contributed to by a variety of factors of which ApoB has nothing to do with it? And if mortality is contributed to by factors of which ApoB has nothing to do with it, should we consider ApoB lowering as a means by which people should significantly live longer? I think that's a curious question to ask. And you're aware of data that our group has generated over time to try to better understand the relationships of metabolic variables and mortality. So at the end of the day, we have seen in well-validated data sets that measures of metabolic vulnerability and inflammation are eerily good at predicting people's death, irrespective of their cause of death, irrespective of cancer, COPD, atherosclerosis, etc. And the model there would say, kind of in a way, getting back to I think a point you were making, that is, metabolically healthy people may be in really good shape depending on what outcome you're interested in. If you're interested in the outcome of mortality, metabolically healthy people could be in really good shape, regardless of whether it's death from heart attack or stroke or cancer or what have you. And so we get back to the idea of the basic value of being metabolically healthy versus individuals who are metabolically challenged and vulnerable. And those individuals are the ones set up for a poor outcome, mortality, regardless of mechanism. Now, wouldn't that be an interesting concept? That we really have undervalued metabolic health. We have undervalued the contribution to mortality of being metabolically healthy. We have overemphasized risk factors, which have really nothing to do with your metabolic vulnerability. And at the end of the day, it's the metabolically vulnerable guy who is at risk of bad outcomes. And I really believe that model has some value to it. And as I think of that model, I am not put off at all by the fact that lowering ApoB may or may not improve mortality. That doesn't bother me a bit. It does not bother me a bit that people can look at short-term LDL lowering trials, 5 years duration, and see in the cohorts that have been studied a lack of a significant signal for mortality improvement, but a signal for significant event improvement. It doesn't bother me a bit. And I don't think in any way that undermines the lipid hypothesis or the value of ApoB as a causal risk factor. I think all of that is still intact. Now, there are certain people who would hear those statements and say, I've lost my mind. But I think what you have to consider is, well, think about infectious disease. If I have two individuals who have a similar organism and a similar site of infection, and one lives and one dies, they both get the same antibiotic. The general explanation for that is the host. The person who lived was a better host. They were stronger. They were not as vulnerable. And the person who succumbed to the disease and the illness was not as robust. And the antibiotic in that model is kind of like a club. I hand you a club, you go beat off the people who are trying to hurt you. If I'm too weak to wield a club, it's not going to help you. If I'm just a compromised individual to begin with, the antibiotic is not magic. I'm just compromised. So thinking through those lenses, and these are data that I'll present at your conference, what do we understand in a new, fresh way about metabolic health, inflammation, and mortality? And if at the end of the day, we need to open our aperture to see that these are key factors and go right into the example you used. Macrophage foam cell formation is the committed step of atherosclerosis, period, end of comment. But I integrated many factors to get to macrophage foam cells. It wasn't just ApoB, and it wasn't just the macrophage. It was a lot of factors which coalesced into macrophage foam cell formation. So this nexus that ApoB is what's being eaten is true. Not all ApoB is being eaten. Not all macrophages are eating ApoB. All right, so there are things going on there that are nuanced and very important. And I think just as you have challenged us to think broadly about lipid metabolism mechanisms and outcomes in lean mass hyperresponders, I want to challenge us to think broadly about mortality and what are right expectations for individuals in a variety of scenarios, one of which is high LDL. To your point, what if there's more than just high LDL to it? What if at the end of the exercise, we have a cohort of individuals who are more metabolically vulnerable and inflamed, and those who are less so? And with the same LDL driver, what would you expect? Not the same outcome, right? So this sort of more comprehensive integrative thinking is where we have opportunities. I hope we take advantage of those opportunities. I hope we ask these types of questions so that at the end of the day, we not only know more, but we can help individuals better. And that to me is very motivating. I want to be able, as best I can, to give an individual a better understanding of where they are, what is it that could be improved, and what are the steps available to them should they choose to do that to get better. Rather than saying 1,000 people like you have this general risk and all 1,000 are going to be treated the same way because that's what we do. That's a terrible way to practice medicine, in my opinion. And it certainly doesn't take advantage of any new learnings.
We'll have to wrap up here in a sec. I wanted to really thank you. You've been so generous with your time, but I did want to do one more call back to Nick and his enormous drive in making this experiment happen. And again, thank you for being the senior author on this paper. Bill, I'm so heartened by this conversation and how well you described the lipid energy model that I'm hoping I can count on you to continue to keep these conversations going with your friends and colleagues. Certainly, this is a big deal to me. It's a watershed moment, I think, and I think in 2024, at a minimum, we're going to see a lot more physiology. We're going to see a lot more research projects put together that can help us test the tenets of this model. And I love how the Oreo versus statin experiment will be a great jumping off point. So once again, thanks to both you and Nick for making this happen.
Well, it's been my pleasure. It's a journey, right? Just remember we're on a journey. And we all come at this from different perspectives, from different starting points and different models that we're working on. And I shared with you what some of the kind of tripwires were for me in trying to better understand lipid energy model, and what would it take for me to take that more seriously. What would it take for me in order to say, yeah, this is more than just wouldn't it be nice if this actually would be something that I think is a new learning that deserves some additional attention. And we're still thinking through what data would help us next. And I think that's what I want to help you and Nick and my colleagues with is, okay, so from what we've discussed today, what are next steps at multiple different levels to improve our understanding, test our hypotheses? Do we have the model nailed? Is the model largely right but needs some improvement due to new learnings? Are there additional parts of this that can be nuanced and layered? Wouldn't surprise me if that's the case, but we're moving in the right direction. And I think if you are objective and you think, in a critical manner, you would look at the data as we have today and come to the conclusion that, yeah, that this is a reasonable, cogent model to work with, and we need to know more about it.
Please tell us about your amazing platform. It's incredible. And I know I hinted to it a little bit earlier, but give me the full pitch, like right now.
Sure. Well, Precision Health Reports is a company that seeks to do what the guidelines ask us to do. We want to take an individual's history, their biometrics, their biomarkers, nearly 40 risk-enhancing factors, and 6 sets of guidelines, and focus that in a very laser-sharp way on the individual so that they will know their individual risk of diabetes, heart attack, and stroke. And as we've said, it's more than just major risk factors. It's more than what's my LDL. It is being able to appreciate all of these details. Now, my colleagues who've done this for a long time are pretty good at taking a history and looking at these pieces of information and coming to an opinion about somebody's risk. That is something that can take a while, both in terms of gathering that acumen and also in terms of trying to decide how much do I weight this, that, and the other. So what we want to do is make it super, super simple. If we want to know diabetes, heart attack, and stroke risk, and we need, by guidelines, to have history, biometrics, biomarkers, risk-enhancing factors, and harmonization of guidelines, how am I going to do all 5 of those things every patient that I see with the time constraints of a usual patient encounter? So what we did at Precision Health Reports was say, well, let's make it easy. I'm going to write one for Dave. I want Dave Feldman to have a cardiometabolic risk assessment. What would happen? Dave would get an email that says, Dave, Dr. Cromwell would like for you to get a cardiometabolic risk assessment. Would you answer a few questions? It's a smart questionnaire. You say no, it turns off questions. You say yes, it turns on questions. At the end of 5 or so minutes, you've answered the questions. Next thing is you get a lab requisition that says we need to get some lab work. Like what? Lipids, ApoB, LPIR, lipoprotein insulin resistance score, glycase, systemic inflammation, Lp(a), glucose, hemoglobin A1C. You get that drawn, and then computers do what computers do well, integrate over a very short period of time, and boom, now Dave has a highly specific report that reacts to all of that information so that now you know metabolically what's going on. Am I insulin sensitive or resistant? What's my metabolic health? What's my glucose? What's my 8-year gender specific diabetic risk in light of my insulin sensitivity and glucose? What is the starting point by guidelines, my calculated risk? What are all my risk enhancing factors? What's my cumulative risk? And then what are some next things to consider, including non-invasive imaging, right? So it's going to prompt you and say at the end of the day, you probably ought to talk to your provider about a few things, including, has anybody ever looked at your arteries? Because that can be a key piece of information. Or if you've told me, it'll have that in there. And so Precision Health Reports gives that as a baseline report. And the follow-up report says, and I can tell you how you're doing over time. Are things getting better? Are you improving? And then you can say, I did what my doctor said. My doctor said I was eating too many carbs and I was too lazy and I needed to change, and I adopted a better diet and I adopted better lifestyle and I did it. And now I'm looking again and I'm better. But I'm not better in ways that necessarily are, oh, look at my LDL good now. Watch my LPIR score improve. Look at my metabolic syndrome severity index improve. Look at my 8-year diabetic risk improve. Look at all these metabolic parameters that are improving. Oh, and by the way, you're probably trending well in some conventional things, including ApoB as well. But the big picture is your metabolic health is going in the right direction. And so now you can be motivated. You can continue along a path where you've been reinforced, because it's like people who are on a diet thinking that I just need to lose a little weight. Well, that goes along for a while, but what happens when weight plateaus? There are non-weight wins that physiologically could be in play. And we do people a disservice by only focusing on one parameter like weight or LDL. We want to focus on the metabolic picture in total and say, and this is you.
I just want to add to that. I've always thought that this was the future. How do you get the expertise of a Dr. William Cromwell to be your doctor everywhere? Well, part of the problem is you're usually getting referred when it's too late. Like the general practitioner is working with the patient, and the things that they should be watching for, the things they should be testing for, are what you instead put in the platform now for preventative care and to address these things now, especially if an alarm is going off that not necessarily a very well-intentioned general practitioner couldn't have detected. And so if you're excited about the advent of AI, and all the tools that you've been seeing, you were putting this out before AI was as big as it is, because you're trying to tackle that very same problem space in a smart way to work towards true healthcare as opposed to sick care. So I have to thank you so much. I've gone through the platform myself, and I'm happy to definitely carry that along. Bill, where can people find you?
So a couple of ways. We can go straight to the website, precisionhealthreports.com. We're also on X. I still call it Twitter. I guess it's X. and other platforms. But Precision Health Reports is the company. PrecisionHealthReports.com is where you can get information. We're happy to also work through on your labs, right? So we have a presence on your portal as well, where people can buy it themselves. We have what we call a B2X model. We have people who are interested in their own health, and they're able to come to us directly and get it. Some come to us through their provider, and the provider orders it. We really want to be very flexible in making sure that as people are consuming information about themselves, we can meet them where they are.
Thank you so much for joining, and I'm very excited to see what projects we have ahead.
Yeah, me too. Thanks a lot.